that someone may have that they are involved in a stressful or dangerous situation, especially with their partner. Formerly known as domestic violence, the name of that changed probably like 10 years ago, but that's what we call it now, called intimate partner violence, really any abuse or aggression that occurs within a romantic relationship that could cause harm to someone, their partner, either an intimate partner, it could be their current partner, it could be a previous spouse or partner. Ultimately, the whole key is to inflict pain on that person, to control that person as well. We've got that intimate partner violence, behavior within the relationship that does cause physical, causes psychological, can cause sexual harm as well. Types of behavior that we may see physical acts of violence like hitting or kicking, sexual violence, unwanted kissing or intercourse, even psychological, telling people that they're no good and what they're doing is wrong, and psychological, because a lot of times there's stalking that's at least initially involved, especially if someone gets a restraining order against somebody else, they'll often have stalking involved with that. They may deprive them of really basic needs, right, of clothing that they need, of food, of going to the doctor to get medication, or even as far as preventing them from getting different types of surgeries that they may need. A lot of times there's intimidation that's associated with this. Okay? If you do this, then I'm going to do this to you, or to the pets, or to the kids. Okay? And then we can have something like reproductive coercion. That's a couple different things. That can be that they are forcing that women partner violence to get pregnant, not allowing them to have prenatal care. It could be that they are preventing them from taking their contraceptive methods. So all of those are different forms of reproductive coercion. And according to the CDC, about 41% of women and about 26% of men have experienced some sort of sexual or physical violence or stalking by an intimate partner in their lifetime. 1 in 5 women have been raped, 1 in 6 women have been stalked, and 1 in 4 women have experienced some sort of physical violence at the hand of the intimate partner. This certainly can occur in any relationship, and oftentimes this starts earlier on in a person's life. About 16 million women, about 11 million men worldwide report that they had their first form of intimate partner violence before the age of 18 years old. So again, this happens frequently, much more frequently than we think, even in the military study. And we do know that when we look at the statistics that females are more apt to be affected than males, but it certainly affects both males and females. About 85% of the time, it's going to be a female, 50% of the time it's going to be a male. And when men are affected, often it's more of a physical violence towards a male. Women, it can be physical, it can be sexual, it can be psychological, any of those forms of intimate partner violence. About 80% of females that were raped before the age of 25. 40% raped before the age of 18. In men, 28% of men said that their rape is before the age of 10. So we, in this lecture, we focus a lot more on females, but we know this happens in males and females. And if they're a victim of rape or physical violence or psychological violence at a young age, this often persists into adulthood. They choose partners then, or they end up being with partners then that continue to abuse them. 1/3 of the time, it's going to end in death for the victim of that. We encourage in all settings, all socioeconomic, all religious, all cultural regions or groups. Millions of people, not just in the U.S., but worldwide, according to the World Health Organization, if you go places like Peru or Ethiopia, 60% rate of some sort of intimate partner violence, usually physical or sexual intimate partner violence. There's a lot of risk factors for the victim that we look at. So oftentimes these victims are younger in age. They're usually recently divorced, or they could be recently separated from a different partner. Okay? Many times they have substance or alcohol or drug abuse that's associated with the relationship. Okay? And many times these victims experienced or saw some sort of abuse as a child, maybe between their parents or their grandparents. Even prior abuse as an adult, the next relationship they get into tends to be more of a controlling and abusive relationship as well. And pregnancy, just the state of being pregnant, it's supposed to be a fun time for everybody, it's a stressful time, but just the state of being pregnant puts these pregnant women at increased risk of abuse. And we got characteristics of the perpetrators as well, right? They really can be any race, any socioeconomic status, as I said, just like we're talking about the victim. Many times these patients, these perpetrators have lower self-esteem, their feelings of inadequacy, they have higher consumptions of alcohol, illegal drugs, just like we talked about with the victims. They're often possessive, they're jealous, they're suspicious of what's going on, they're paranoid that someone's always doing something behind their back. And they tend to be controlling of every single day activities, whether it be just their partner or the children and what they're doing, finances, social events, when they can go, where they can go. Oftentimes they will isolate the victim from the family to help to maintain control. Again, most of the time, just like we saw with the victims, these perpetrators often witness some sort of violence when they were growing up. Maybe it was their parents, maybe there's grandparents, aunts, uncles that they lived with. Right? They feel like because it was something they learned when they were growing up, this is what you're supposed to do. This is a reasonable way to solve the conflict. If you're bad-mouthing me and I punch you in the face, you're probably going to stop talking to me. So it's reasonable for me to do that because that's what I saw when I was growing up. They accept violence because they feel like it's a norm for them, because that's what they've been around. And oftentimes their friends are abusers as well, right? Because if they go to their friend's house and their friend's an abuser and say, you know, my wife, I went home yesterday and that dinner was not on the table, and I told my wife to have that dinner on the table. And what is the abuser friend's gonna say? Well, did you slap her? Did you take care of her? Do I make sure that doesn't happen again? So they need to be around people that believe the same way that they believe. Why do victims stay? And a lot of us will never understand why victims stay. But according to the research, according to the literature, it's this cycle, the cycle of events that occurs. In stage one, we have this building of the tension. Usually there's some sort of stressful situation, maybe something happened at work, maybe there's a financial stress, maybe physical illness, right? Maybe there's family issues already. So the abuser starts to exhibit these signs of anxiety, okay, of anger, again, injustice or paranoia. Okay? The victim recognizes this and now starts to become anxious around the abuser, more guarded, afraid to speak or afraid to do anything because they understand, they've seen this typically before. The next stage then is the incident itself. Okay? And this can vary, you know, might be physical, might be emotional manipulation, verbal threats, name calling. So this is the point where the victim says, man, I need to get out of this relationship. This is where they really clearly understand that there's a problem within the relationship. Okay? But after the incident occurred is the reconciliation phase. The reconciliation phase, the abuser comes and apologizes. I'm sorry that happened. It's not that I'm sorry for what I did. I'm sorry that it happened. Meaning, if you wouldn't have done X, Y, and Z, it wouldn't have happened. So they don't really apologize that it happened, or why they did it, or apologize for the fact that they did it. They're apologizing that it happened at all, but you as the victim, if you wouldn't have done this, if you would have had the laundry done, if you had, you have done these things, it wouldn't have happened. So they apologize, essentially saying that it's the victim's fault that it happened, and we're trying to make sure it doesn't happen again. And then the last phase is the calm phase, the honeymoon period, as we call it. Okay? Here, things are so good that the victim almost forgets that anything even happened. She actually talks herself out of the fact that anything happened, or you're right, it probably was my fault. I've got to be better at this. I've got to do better. I've got to make sure that I do these things correctly, and ultimately everything is going to be much better. This is not going to happen again because I'm going to make sure that things are better. But we know, because this is a cycle, we don't end at the calm stage. We're going to go back to number one at some point. And it might be, might be a month from now, might be 6 months from now, might be a year from now. It's almost always going to happen. So the problem, again, is that these cycles, typically over time, will increase in frequency. They result in worsening violence, worsening emotional and psychological violence against the victim, and a lot shorter honeymoon phases as time goes on. Self-esteem is ultimately affected. That results in these victims being kind of isolating themselves. They're already typically isolated to a degree because of the partner, but now they're isolating themselves even more, which makes them more dependent on the abuser. Okay? I can't go anywhere because I don't have the money. I can't do this because, I'm so used to this other person being around. So really our role is, as medical providers, is to identify that this is happening, to pick up on the clues that something doesn't seem right with this patient. So maybe about 3 weeks ago, we had San Antonio Police Department bring in 2 women that were involved in a car accident. And, or I guess they came in by ambulance, and the SAPD was there. And there was just something, we have, for many years, we didn't have SANE nurses at AMC, but now we do. We have sexual assault nurses, now we have them. But they went in, they evaluated, they do that with every trauma now. And they picked up that something didn't seem quite right with these 2 women. So these women were bad enough off, and they admitted them upstairs, and they went upstairs and talked to the women again, and they said, something's not right. So they had some other specialized people come and talk, and ultimately both of these women were being trafficked, and it was identified. And these were not military people, they were non-military, but it was, and I did have conversations with nurses about it. I think what they said, that there was just not, they weren't answering questions you can tell really truthfully about, what happened and where they came from, and did they have any, children, or what a spouse and all that. So it was very minute things that they just said something's not right. So we're going to talk about what those things might look like. So again, oftentimes this is difficult because the patient doesn't report it. It's not reported to authorities, and you don't have to report it to authorities. It's not even reported to healthcare professionals because many patients are embarrassed by the fact that they're in these relationships. And again, we're kind of protected in the military setting because we don't see a lot of this. Anybody that's ever been at Bragg, there's been multiple incidents over the last 10 or 15 years at Bragg where spouses ended up dead on post in military housing. Again, and they've been seen multiple times in the clinics where there was a matter of death on. So think about, these patients might come in with more chronic disorders, backaches and headaches. They might have irritable bowel syndrome, constant fatigue, oftentimes complain of constipation, diarrhea, and eating disorders. They may have this underlying depressive kind of behavior that you can pick up on. Usually if they're pregnant, oftentimes they come in later in the prenatal course because they're not allowed. So if they're coming in later on, like, why didn't you get prenatal care before? It doesn't make sense, especially in the military setting when it's offered for free. Why is someone would come in later on? oftentimes are seen in the emergency department. Why? Because how often do you see the same person in the emergency department? Hardly ever. Every time you go in, it's somebody new, somebody new. And so they figure out that if they can see somebody different from these multiple complaints, that it's not likely that that person will have enough time or spend enough time with them to figure out what's going on. Again, when they talk to these patients, they're often either very flat or depressed affect, they usually don't have any eye contact with their partners with them. Where's the partner going to be? In the room with them. Who's answering the questions? Partners answering the questions. And that's literally when you look to them and say, thank you, but I need to make sure that I get the answers from this other person. So, I mean, I've done that multiple occasions. Thank you for being here. I appreciate your input, but let's let the patient speak, just so I can make sure I document their patient. Okay. So oftentimes our partner refuses to leave. So sometimes you'll have to say, you know what, I've got to take this person over to X-ray to get an X-ray done, and unfortunately they don't let anybody else come in because it's a really small area. So we'll have to have you sit here, and then you'll take that patient personally over to X-ray or over to lab, or wherever they have to go, and then you can ask them questions during that time. And sometimes they'll answer, and sometimes they won't. On physical exam, you want to look for, you're not going to typically have evidence of physical abuse on their face or on their hands. It's usually going to be more central, places that they can hide. Upper arms, upper legs, and then the torso. Okay, bruises often are in various stages of healing, bruising or abrasions, cuts and scratches. Okay, make sure that you look for any sort of injury. If you're wearing a turtleneck, this may be the time that you in fact say, I need you to put a gown on so we can do a complete examination instead of you're there for abdominal pain. You get some kind of a clue that there's something else going on. So look for bruises around the neck or hand marks around the neck. Silence hides violence. This is a worldwide campaign that came out several years ago. And this really just encourages victims to speak up. It says that victims should not be muted, they should not be ignored, because if they are, then the damage is widespread. Often it's passed on to their children and their children. So as clinicians, we've got to be aware of the signs and the symptoms, because oftentimes they're very, very subtle. The majority of the places that you guys are working, every place that I've ever worked, they do this universal screening when the patient comes in. They ask them, do you feel safe at home? Is anybody hurting you at home? Again, that's often not enough because we spend about 30 seconds to a minute in triage, and then they're put into a room. So we have a little bit more time in the room to talk. You've got to be willing to ask the uncomfortable questions. That's part of the problem. Especially if you've ever been in that situation, it's hard for you then to ask somebody about the question because you didn't want to be asked about those situations or those questions. Okay? But the problem is we've got to be able to ask those uncomfortable questions. A good memory jogger that we can use to help us assess the situation if we think someone's in a toxic relationship, we can use this mnemonic SAFE. Okay, so S is, does the patient feel safe at home? Okay. Has the patient ever been abused by a partner? Okay, or is the patient afraid? So they can be afraid or abused. Okay, F, are there any friends or family in the area as kind of a safe haven or for support that they can rely on? And E, what is the plan? What is the emergency plan if something goes bad? Okay, do you have phone numbers for people to call? Do you have a call? Do you have a phone? Do you have money? What is the plan of exit? And then for our screening, okay, we know based on literature that if a healthcare provider directly asks the patient, is someone hitting you? Is someone abusing you? They're more apt to answer. Okay, so we want to be able to ask those direct questions. We can use this mnemonic for radar. So we're going to ask them frequently, okay? By the time they come in, ask them directly, document what the patient says, assess their safety, now you look in the eyes when you're answering their questions. And then let's see what option they have in the area if there's no friends or family available. Okay, so again, routinely ask. This is usually done by a universal screening at every healthcare facility in the military, and then the healthcare facilities I even work on the outside, they're going to routinely ask these patients in a safe and secure environment, ideally away from the department, right? A lot of times we don't pick these clues up immediately. So the first evaluation when you're in that triage area, oftentimes that partner was in there with them. So if there's something that's not right, then that's when we're trying to move them to a different area. Why, outside of this universal screening, and we think about why aren't we able to pick up on these clues, or why do we have so much intimate partner violence? And it's because most of the time we're not trained on what questions are asked or even how to ask them. We want to ask them in a non-judgmental way, kind of a compassionate voice. Well, I spent a lot of years in the military, 20 plus, and I can tell you about how much compassion I had when I was seeing patients every 15 minutes, right? Even when I first retired, like people would come to the ER, why are you here? Why did you come here? What's going on? Why are you, you're just more aggressive in the military because that's the nature of our business, right? So now I'm asking you to pull up that chair, have them sit next to you, spend a little bit of time with them. And maybe not time that you have. So time is a problem. We think about, cultural prejudice or socioeconomic prejudice. You live or you work in a community that is machismo. Males are in charge of that community. So when a female comes in, like if there's something is going on, we just expect that that's going to happen in that type of community. And again, maybe there's personal history of abuses, so we don't want to ask those questions. We're afraid to ask those questions to those patients. But we want to make sure we are, in fact, routinely asking these questions, not only in the triage area, but when you get the patient back to evaluate them for whatever their chief complaint is. They ask these questions directly. Are you in an abusive relationship? Have you ever been in a relationship where someone physically hurt you or they threatened you? Have you ever been hit or kicked or punched by your partner? And do you feel safe at home? I noticed that you have a number of bruises on you. Did someone do this to you? Okay. So I noticed you have a number of bruises on you. How did that happen? Did someone do this to you? We're asking specifically if there was a physical altercation between them and somebody else. You want to make sure you document your findings. Record how that patient described it to you. This is when we use statements like the patient says, or she said, or he said. Okay, what about your physical findings? You want to make sure you document all your physical findings as well. Oftentimes, if there's multiple physical findings, you use a body map, so it's just a basic map of the body, and you can mark those areas on the body map and use that for documentation. We can photograph the injuries, especially if there's a lot of injuries. Now, do we do that with our personal phones? Probably not advised. There's medical photography people in some of the clinics, and certainly if you're working in a hospital, there's a medical photography people. And they'll come in, they'll take the photos, they'll run it up the chain, and then they'll ultimately will upload it into the patient's medical records. Okay. And then remember that this may end up in court. So you don't want to rely on your memory if this ends up in court. So make sure that you document everything so that if it does end up in court, you can refer back to the documentation. This is what the patient said, and this is what I saw. The first aid of the radars is assess for safety. Again, before that patient leaves a medical setting, you want to identify if they feel safe at home. Are they afraid to go home or not? Okay. Has there been increasing frequency or severity of the violence? Are there any weapons at home? Guns? Everybody has knives and steak knives. Okay, so are those things accessible? If there are guns, where is the ammunition, where's the gun? Do you have access, does your partner have access? Someone has access, I'm sure. Okay? And what about children? Okay? Children or even pets at home. Because sometimes that partner will use those children, use those pets as pawns against the other. We've got review options and referral. So certainly if the patient you feel is in imminent danger, we've got to figure out, is there someone in the local area that they can stay with? Do they need immediate access to a shelter? What shelters are around the area that you're going to be working? Okay. What about access to hotlines? Do they even have a phone? Remember though, that sometimes it's dangerous for these victims to have phone numbers in their pockets or cards in their pockets, because that partner oftentimes goes through everything that they have, and they're going to take that card and they're going to take that phone number, and it's going to be used against that victim. So though we want to make sure again that there's an exit plan before these patients go. So that exit plan is this. Do they have money? Okay? Do they have some sort of credit cards or a savings account? How can they get from point A to point B on what money? Okay? What about key documents? If you have kids at home, where are the birth certificates? Where's your social security card? Do you have a small bag that can be packed and stowed away somewhere hidden that you can grab and go? Okay? Is there someone locally to stay with, or do you know where the nearest shelter is? And would you have a phone numbers to those shelters? How are you going to get a hold of anybody? Do you have a cell phone? Do you have a calling card that you've hidden away somewhere? Okay. And once this exit plan is created, every time that patient comes in, you review the exit plan. It's not a once and done, you've got to review it. Because things change, right? Kids move out of the house, different partners change, different bank accounts change, things like that. Despite the significant prevalence of intimate partner violence worldwide, mandatory reporting is often not required. In the majority of states, they do not require mandatory reporting, which is different. Child abuse, elder abuse, we've got phone numbers we can call for them, right? But not for intimate partner violence. So depending on the state that you live, so you have to know what the laws are in the state that you live, but the majority of them is not mandatory to report. There are some states that require reporting only if the injuries that occurred were from a weapon, so a knife or a gun, so in case was shot or stabbed, that's the only time you have to report. There's other states that say only if there was a criminal law that was broke as part of this violence, then you have to report. But I think well over half of the states do not require it. 7 to 10% of these victims are going to be pregnant. Oftentimes, it was probably a degree of intimate partner violence before the pregnancy, and then again, just the state of being pregnant caused a lot of stress on family. Maybe this is kid number 5, they didn't want that, and so that increases the likelihood of IPV during pregnancy. And then we've got serious fetal complications, serious maternal complications, all the way from preterm labor, preterm delivery to death that's associated with IPV. So as part of prenatal evaluation, from the very beginning, they're going to start asking about IPV, and then every subsequent visit, they're going to ask every single time about IPV for these patients. Anyone that has been in an abusive relationship or even has seen an abusive relationship from their parents, they're at much higher risk for chronic problems, not only chronic medical, but even chronic psychological, depression, anxiety, increased risk of substance use and substance abuse. Many of the time, these victims have a hard time holding down a job. They're often left with nothing, and because the abuser will take everything, that puts them in a much lower socioeconomic status. Okay? They often usually have limited income, limited resources. And then again, about 4,000 people will die at the hands of IPD every single year. Kids, this also affects kids. Kids have long-term effects when they see their parents fighting all the time, especially physical altercations, increased risk of depression, anxiety, and suicide as teenagers for those kids that were exposed to that. They often will perform poorly in school. They often don't go to social events like dances or school parties because they feel uncomfortable, and even sometimes they're not allowed to go. Many of these kids, unfortunately, witness this abuse when they're younger, and ultimately they become abusers as well because they see it as a normal part of life. This repeat pattern of abuse from kid to adult. So again, why don't these people leave? We have the cycle of abuse, we have that for sure, but also fear. Where do I go? Where do I go if I leave? I have nothing. I have, $1 in my pocket. I don't have a phone. I don't have access to go anywhere. So fear of leaving, fear of retribution towards the kids. Okay, it's always going to be said that if you leave me, I'm going to kill you. I'll kill you. I'll kill your kids, and I'll kill your family too. Right? So that's a common, very, very common threat. This is the only person that the victim has been with. I don't want to be alone. I'd rather be with this person than be alone. So there's also fear of isolation. Because there's no mandatory reporting requirements in the majority of states, there's also a thought that law enforcement's not going to protect me. So my sister has 5 boys. One of my nephews, a couple of my nephews are not great people. I mean, I really wish they were in jail for their entire life because society would probably be safer. But one of them, not that long ago, I think 2 years ago, held his girlfriend at gunpoint in the bathroom of her girlfriend's house. Shot through the roof. I mean, it was just chaos, right? Do you think anything happened? They did take him to jail for a week, and then they let him out. And at 2 a.m, she's calling me on the phone like, he's back, he's back, he's back. So it's really common in San Antonio that we will call SAPD on people like, when we know it's intimate partner violence. And what do they say? There's nothing we can do. This is a family problem. There's nothing we can do. Okay? So, which is frustrating as healthcare providers, right? It's frustrating because we can only do so much. We want to keep people safe. So these patients have no thought that law enforcement is going to protect them. Matter of fact, if they call law enforcement, they're more apt to get killed because ultimately that person's going to get out of jail and come back and kill them. And my nephew did. He went back. He didn't kill her, but he went back to kill her. And she had already and then fear of legal proceedings, fear that they're going to lose the children because that's always going to be part of that issue. I will take the children from you. You don't have a job. You don't have any money. You have nothing. Without me, you're nothing, so I'll take the children from you. Okay? So it's not worth it to them. They'd rather just stay in that relationship. Our job, again, primarily is to just pick up on those small clues because they're going to be small clues. Okay? I've only I've been in medicine for 30 years. I probably 3 or 4 times I'm like, something's not right. And I just can't even imagine how many times I missed it. So you've got to be able to spend the time with these patients, as busy as your schedule is going to be, seeing patients every 15 to 20 minutes, spend the time and try to pick up those clues. And really this is for the Reserve and National Guard folks, which you're going to be out there seeing patients outside of the military setting. You're going to see a lot of this, especially in rural areas. Okay? Now let's go into sexual assault. Okay? Sexual assault, sexual violence or activity from one person on another when they don't give permission. Okay, so permission is not freely given, it is not obtained. It often involves some sort of aggressive behavior, some sort of violence that's associated with it. Affects millions of men and women a year, but again, it often goes unreported. Okay? And it impacts everybody, okay? All genders, all sexual orientation, all ages. Okay? This can occur in person, it can occur online, it can occur through via sexting, okay? The sharing of the sexual pictures without somebody's consent. Okay? Anytime that occurs without somebody's consent, that is considered sexual assault. When these patients come in, initial evaluation is going to be identifying any life-threatening injury. That's going to be number one priority. Okay, 70% of sexual assault victims have no obvious physical injuries. 24% will have some minor injuries. Okay, 5% have those large injuries, big lacerations, large hematomas. Okay, maybe significant head injuries that's associated with that as well. 11% significant internal injuries. And then 2% are going to have some sort of gunshot, knife wound. So we got 5% are major, but of those 5%, the majority are still going to be some minor stuff. And then all the way up 2% where they come in and been stabbed multiple times or shot multiple times. For the sexual assault portion itself, the physical exam, the most common area in a sexual assault that is injured, the genital area, is going to be the posterior fourchette. And that's usually because it's aggressive intercourse with these patients who are fighting and fighting and fighting. And then with the penetration, with the aggressiveness of the penetration, they'll tear that posterior fourchette. So that's going to be the most common area that you're going to see. When you see injuries there, you really got to take some time and talk to these patients and figure out what really happened, because it's really concerning for some sort of assault. So it depends on where you're working, will depend on who's going to be performing the sexual assault exam. Oftentimes it's going to be someone from the local emergency department that you'll send these patients to, or hopefully you have a hospital that has somebody specifically trained in sexual assault. It's called the SANE nurse, sexual assault nurse evaluation. And it's really nice to have a SANE nurse, because those people go to specific classes, so they've learned how to manage these sexually abused women, how to talk to them, how to keep them calm, how to manage them in terms of a compromised psychological and physical state as well. Even more important, they know how to collect the evidence. It's really important that you collect the evidence exactly the way that you're supposed to. Otherwise, you can't be used in a court of law, if this calls be used in a court of law. And they know what the proper chain of custody is, and they also know the services that are available for these victims of sexual assault, what consults they should put in, what referrals need to be put in as well. If you find yourself that you're the one that's seeing this victim, okay, you've got to be in a really good history. Okay? You've got to have really good documentation to this patient. So find out, when did this happen, about what time did it happen, where was it at, were there any weapons involved? What about, did they have any loss of consciousness, were they hitting their head, pushed on the ground, or any blacked out periods where they have memory loss? What was the specific type of penetration that occurred? Was there any bleeding? Do they know if they bit the victim or not? Do they know if they had scratches? They're going to take fingernail clippings and send all of that off. Prior to this incident, when was the last time you had consensual intercourse? Because you'll need to know that in case there's different types of sperm from different people that are found. Okay? After this happened, did you shower? Did you change your clothes? Did you brush your teeth? Did you clip your nails? What have you done since the incident? Okay? And what about law enforcement? Okay? Law enforcement can be contacted, but it depends on the state. It also depends on the patient. patient does not have to report this. Okay? If the patient chooses to report, it can be put in a restricted file or an unrestricted file. Okay? So again, they don't have to, but if it's put in a restricted file, that means they're going to have access to only certain people. Okay? Until that patient says it can be unrestricted, and can go to court of law. Okay? They can change their mind at any point. If initially they say I want it restricted, okay, then they want it ultimately make it unrestricted, they can do that. But they do not have to, even in a military setting, they don't have to necessarily report this. Before you perform a physical exam, you gotta have a chaperone, and you've gotta get consent. Those are things that must be done. If you don't get those two things, it's not gonna be admissible in court of law. Okay, so the other thing is by obtaining consent, you're kind of giving that victim back some of the control that they have lost. You know, be specific with the documentation, be specific with the details that the patient is giving you. He said, she said, write those things down. You document the emotional state. Is the patient seems pretty calm? Is the patient anxious, depressed? Like what is the emotional state? And you know, don't be judgmental about the emotional state. There are bad things that happen to people, and they can still remain very, very calm in those situations. There are certainly people that complain that will claim that they were sexually assaulted when they completely weren't sexually assaulted. It's not your job or my job to figure that part out. We just want to collect the evidence and get the data so we can document that. And then that figuring out if it really happened is someone else's responsibility. If there's any evidence of trauma, again, we want to make sure we take pictures. Ideally, we'll call the medical forensic photography, and they'll come up, and then we'll take the pictures of the specific areas of trauma, and they'll document that. And that's both extra, non-genital and genital areas. We talked about colposcopy. Usually you're not going to have that available. You not have colposcopy available, but colposcopy, remember, is just a big magnifying glass. And so it helps us look for evidence in the genital area that might be small areas of evidence that we can see a little bit closer. I like using a UV light. Okay? So usually what will happen is when these patients come in, we'll have a white sheet that's laid down on the ground. They'll undress on that white sheet. If those are not the clothes that they were wearing, like a sexual assault, hopefully they brought them in, or we'll get them from the patient. We'll put that in a bag. If those are the clothes, all those clothes and everything go right on that white sheet. That white sheet and everything goes to forensics, because there might be pieces of hair, pieces of lint, things on. Anybody watch forensic files? Like that's how that stuff happens, right? So they have all that, and they're able to see. And then the UV light. UV light will sometimes. You can see semen via UV light. Sometimes you can see like little fibers from that UV light. So take that UV light from top to bottom and use a UV light. It's the same, you know what I'm talking about UV light? The same one they use if you're going to check the eye for coverage. Top to bottom, genital area as well, so that way you know you can swab those areas. Otherwise, we typically swab everywhere. Top to bottom, left to right, all the orifices. Remember that even if the patient agrees to the exam, it doesn't mean that they have to press charges. That's going to be up to the patient. But the exam should be done, and all that evidence should be collected. We're going to document. And remember, again, we don't want to rely on our memory of what the patient said. We rely on our documentation of what we put down. So you know, if you put it there, it is what happened. If you didn't put it there, then that's not the story that you got. The exam itself, depending on the state, it can be done to 1 week is usually the latest. Here in Texas, it's 96 hours, and that's after the assault has occurred. And so you got to figure out what your laws are in the state that you're in. Again, all the clothing, we want that to go to forensics. We're going to swab inside the mouth. Inside vagina, the rectal areas. Okay? Any areas that are highlighted by the UV light, we're going to swab those areas, and those will go into the forensics kit as well. Usually we're gonna comb pubic hair and comb the hair on the head, so I'm gonna send that off. Samples of the hair will go, fingernails will be trimmed, that will go. If you're gonna be doing this, there's a forensic kit, and that forensic kit has a step by step by step. This is what you do first, then this, then this, then this. If you do not do it again in in a stepwise fashion, it can be admissible in court, so it can't be used in court. So you gotta be really, really careful if you're gonna be doing this. It is recommended to offer these patients STI testing, at least STI testing and treatment. So you can offer, they don't need to take it, but you should at least offer. And then immunizations as well. Having immunized against hepatitis B, drug screening is often recommended, and then pregnancy tests is often recommended as well. We're going to treat, obviously, if there was any significant physical injuries, we're already going to treat that. We're going to talk to them about STI prophylaxis. Emergency contraceptive may be needed. Remember, you need emergency contraceptive for up to 120 hours after the incident. And there's a couple forms of emergency contraceptive we can use. And then this has a lot of psychological trauma on these patients. So what do we do? Who can we refer them to? We need to know in the military setting and outside the military setting where we can refer these patients to for further evaluation. Where are they going to stay? Are they staying at home, the local shelter? Do they feel comfortable going back to the place that they came from? Or maybe this incident occurred. We've got to be able to figure all of that out. These patients need follow-up as well. So again, that's a really nice thing about the same nurses, is that they'll follow up with these patients. They need repeat HIV screening, usually 3 days, 6 weeks, 3 months, and then 6 months. Okay, and then usually follow up with the clinic within 1 to 2 weeks for just a reevaluation. How are they doing? Let's review the labs that were done. Let's make sure all of that stuff is okay. What are the long-term consequences that we see with these patients? You can imagine. Post-traumatic stress disorder is one of the main issues that we get. A lot of these are psychological nature, depression, but they can have sexual dysfunction, cervical cancer. And why? Because usually when these sexual assaults occur, they're not using protection. So now this patient may have got HPV, and depending on the age when this occurs, if they don't get additional screening, they increase their chance for cervical cancer. Certainly, they could get pregnant from the sexual assault. And then ultimately, we have this thing called rape trauma syndrome. So rape trauma syndrome encompasses 2 response phases to sexual assault trauma. The first phase is the acute phase or the disorganization phase, and this lasts the first several weeks. During this phase, this is more of the shock and disbelief phase. They're fearful that it's going to happen again every time they go out anywhere, but they're also at the same time blaming themselves that it happened. They're ashamed that it happened. They feel humiliated in one aspect, and then in the next time they turn around, they're angry about what happened. They oftentimes feel like they have no control over their life since this happened. Again, that lasts for the first couple of weeks, and then for the first 7 weeks, usually 4 to 6 to 8 weeks. And then we have this delay or this reorganization phase. Here, they're trying to, these patients have more feelings of vulnerability, more despair, guilt. That shame may continue as well. They have a lot of anxiety associated with this, a lot of chronic depression, insomnia, they're not sleeping very well. And that can last from several weeks to the rest of their life for several years. So again, where you're at, you don't need to obviously remember the resources, but just know wherever you're going to be working at, know what your local resources are, know what the national resources are as well for these patients in case you come upon this in your practice. Okay, thank you.